guest speaker เป็น lunch symposium นะครับก่อนที่เราจะทานอาหารกันก็จะใช้เวลาไม่นานนะครับเราก็กำหนดวิทยากรว่าไม่ให้พูดเกินครึ่งชั่วโมงนะครับก็เราได้รับเกียรตินะครับเดี๋ยวผมแนะนำก่อนแล้วก็เดี๋ยวเชิญวิทยากรมาก็เป็น associate professor Yasushi Suzuki นะครับก็มาจาก department ของ critical care medicine Iwate Medical University ที่ตรงซัปโปโรนะครับอาจารย์ก็เป็นหมอ urologist นะครับแต่ว่ามาทำเรื่อง critical care แล้วก็จะมาพูดว่าทำยังไงให้ผู้ป่วย severe sepsis เนี่ยในโรงพยาบาลของท่านเนี่ยมีอัตราการตายซึ่งต่ำกว่า 10% นะครับเราลงมาแชร์กันว่าที่ต่างประเทศเขาทำยังไงเรื่องเกี่ยวกับ infection นะครับแล้วเราก็เดี๋ยวก็จะเลคเชอร์เป็นภาษาอังกฤษผมอาจจะต้องช่วยคือถ้าอาจจะฟังยากนิดหน่อยแต่ว่าก็เดี๋ยวเราลองมาดิสคัสแล้วก็ถ้ามีคำถามเรามาถามหรือว่าลองให้ความเห็นกันนะครับเดี๋ยวผมไปเรียนเชิญโปรเฟสเซอร์ก่อนก็ร้านซิมโพเซียมนี้ก็ได้รับการสนับสนุนจากบริษัทโทเรนะครับซึ่งโทเรเองก็จะเป็นบริษัทซึ่งดูแลเรื่องอุปกรณ์ในการรักษาคนไข้เซปซิสอย่างหนึ่งก็คือเป็นโพลีมิกซินโคนะครับทำในการ remove toxin ออกมาจากคนไข้เซปซิสนะครับก็ต้องขอบคุณทางบริษัทด้วยนะครับที่ให้การสนับสนุนในการประชุมครั้งนี้ Okay, please go ahead.
At first, Sawadee-Kap. Konnichiwa. Thank you very much, Dr. Chenchai and colleagues. Thank you again for invitation to this excellent meeting in Thailand on World Sepsis Day. It's my honor to present about our sepsis management and treatment to you. Today, I would like to talk about treatment in patients with severe sepsis and/or septic shock in Japan, especially in our hospital. At first, I'm just working on Department of Critical Care Medicine at Iwate Medical University in Morioka City as an emergency doctor. Morioka City is located on north area in main island of Japan. And you remember, we had a big earthquake and tsunami in 2011. Thank you again for your help and deeply consideration of Thai people. Iwate Medical Hospital is located in downtown of our city. We can see a beautiful mountain from hospital. We also have Iwate Prefecture Advanced Critical Care and Emergency Center with this university hospital. We have a wide space for initial treatment of patients in this center. Many women doctors work at our critical center, and this slide shows that she performed relief incision to a patient with a severe burn. About 30 doctors are working at this center as an emergency doctor. And we also have a plan to move new hospital to area in suburb of our city. We have also doctor health system, and our medical staff is also working as a flight doctor. And Dr. Health usually operates for patients with a severe status like cardiovascular disease, and stroke, and trauma, and severe sepsis. And this is content of my presentation today. Is sepsis still a problem, ICU? Sepsis accounts for 50 to 60% of ICU cases. You know, tomorrow, 13th September, is World Sepsis Day, announced by WHO Alliance. People die once in every few seconds by severe sepsis in the world. Indeed, sepsis gain attention to, yet still a long way to go to increase the highly needed sepsis awareness. This slide shows cause of sepsis. In Japan, we have patients with severe sepsis caused by respiratory infection, peritonitis, including after surgery, urinary tract infection, soft tissue part infection, et al. In data in Europe countries, respiratory infection is the most frequent causes of sepsis. But in our hospital, peritonitis is the most frequent causes. From 1991, systemic inflammatory response syndrome was established, and blood temperature, pulse, respiratory rate, white blood cells were needed to check. SARS diagnosis when the patient satisfied two or more conditions as these abnormalities. Definition of sepsis from 1992 is that SARS induced by infection. But you know, a new definition of sepsis was published in this year. Sepsis is an organ dysfunction caused by a dysregulated host response to infection. And severe sepsis patients have multi-organ failure. When the body is subjected to major damage, shock, and disseminated intravascular coagulation, which is so-called DIC, acute respiratory distress syndrome, ARDS, acute kidney injury, hepatic failure, often developed and lead to multi-organ failure. Flow chart of bacterial infection of sepsis is indicated in this slide. Cytokines, which are IL-6, IL-8, TNF-alpha, IL-1 beta, and endotoxin, plays a central role in the pathophysiology, and cytokines also trigger the production of many mediators. PMX, tremixin direct hemoperfusion can remove the cytotoxic substance and endotoxin. And the tremixin column contains a rolled sheet which is filled polymyxin B, which is antibiotics with a strong effect on gram-negative bacterial infection. We usually perform this PMX using direct hemoperfusion. I will present you sepsis-related best practice cases using PMX in my presentation. On the other hand, Surviving Sepsis Campaign Guideline was made and published to improve the mortality of sepsis on 2004. Early goal-directed therapy by Professor Deringer was used as initial resuscitation for septic shock. And from 2003 to 2007, 5 years period in USA, hospital mortality was decreasing in patients with severe sepsis. But 28 days mortality is approximately 30% in USA. I think this data is still high mortality rate. Next, I talk about the sepsis management in our ICU. Mortality rate in our ICU was about 22% in 1980s, but now this rate is less than 10% in our ICU. This slide shows protocol of treatment for sepsis in our ICU. We needed to examine about the measurement of endotoxin, procalcitonin, presepsin, which is so-called soluble CD14 subtype, as a new marker for early diagnosis for sepsis, at least within 3 hours. And reagents for sepsis treatment are used as soon as possible. We can use the immunoglobulin, protease inhibitor, antithrombin, recombinant thrombomodulin, and sylvester sodium hydrate in Japan. After early goal-directed therapy, patient is still shock vital. We immediately performed PMX-DHP. Our goal is 28 days mortality, keep less than 5% for patient with Apache 2 scores average 25 points. And we usually examine these markers, cytokines, including IL-6, IL-8, endotoxin, beta-D-glucan, procalcitonin, and CD14 subtype for diagnosis of sepsis. I think examination of this marker is very important for treatment and management of sepsis. In Japan, we had the strategy for hypercytokinemia. However, patients with sepsis have no acute kidney injury. We performed treatment using acute blood purification system for hypercytokinemia. Anyway, there is no strategy for hypercytokinemia in Surviving Sepsis Campaign guideline. Endotoxin is a lipopolysaccharide and a component of the envelope of gram-negative bacteria. Intravenous administration of lipopolysaccharide caused by shock and other severe status. We developed a measurement of endotoxin using high-sensitive endotoxin assay. Cutoff rate is 1.1 picogram per ml. We need information about the endotoxemia before treatment, including PMX-DHP. In Japan, patients with septic shock caused by endotoxemia or suspected gram-negative infection could be taken the PMX-DHP treatment. PMX is covered by health insurance up to 2 columns in Japan. Clinical efficacy of PMX is that PMX-DHP could remove endotoxin from blood, increasing of blood pressure, improvement of PF ratio in patients with acute lung injury and ARDS, increase of urine output volume, and other effects. Finally, hemodynamics is significantly improved by PMX-DHP. UFAS randomized control trial from Italy showed improvement of 28 days mortality by PMX-DHP in patients with abdominal sepsis. Endotoxin shock leads to production of many cytokines. Let me show you anandamide and to cause activation NF-kappa B cells, finally increasing of HMGB1 in blood is observed. And so this slide shows a rock-splitting cherry tree in our city. It's a very beautiful cherry tree. And so let me show you our examination of diagnosis of sepsis. Urinalysis is a simply test using microscopy for detecting urinary tract infection. And this is a semi-quantitative measurement of procalcitonin in patients with urinary tract infection. On admission in our hospital, procalcitonin could be detected as a strong band, but after 21 hours, band disappeared in spite of increasing CRP. However, procalcitonin indicate high level in any bacterial infection. Now we introduce new marker, which is so-called Presepsin, as early diagnostic tool for sepsis. And recently, one of the production mechanisms of Presepsin has been proposed that is related to bacterial phagocytosis. Bacterial and membrane CD14 is incorporated in granulocyte by phagocytosis. In the phagosome of granulocyte, membrane CD14 is cleaved by lysosomal enzyme. After that, Presepsin released in bloodstream. And this is a rabbit septic CLP model. IL-6 value is already known that IL-6 rise up early in septic patient. In this model, IL-6 rise up 4 hours after infection. However, this is IL-6 data. IL-6 rise up 4 hours after infection. However, Presepsin rise more earlier than IL-6, but about 2 hours after infection. And next, I introduce expression of Presepsin from human monocytes and neutrophils. According to paper from Kyoto University, Japan, then this study used human cells. Please look at control Presepsin is not exit. And then after E. coli put into monocyte, we can detect expression of Presepsin. So Presepsin was produced from mainly monocyte after phagocytosis. We can measure Presepsin level using immunochemical activity by bedside. This device is PassFirst, made in Japan by Mitsubishi Medical Corporation. And we can get data about 15 minutes using 100 microliters of the whole blood of the patient with sepsis. And significant correlation was found between the serum Presepsin level and APACHE-2 scores. Significant correlation was also found between Presepsin and SOFA score. If the patient undertaken with hemodialysis, we need to use caution to detect Presepsin level, because these patients have a high level of Presepsin with any infection. In short summary, the most important bundle for treatment sepsis, early diagnosis and early treatment, including sepsis, including sepsis, are performed at least within 3 hours. So I will present the best practice cases using PMX-DHP. Patient was undertaken total cystectomy because of bladder cancer in another hospital. The 3rd day after total cystectomy, patient were indicated data indicate multi-organ failure. Abdominal findings showed necrotizing peritonitis because of perforation of small intestine. Apache score was 37 and the patient has septic shock status. E. coli was found from culture of abdominal cavity and blood. You can see edematous and infectious small intestine. PMX-DHP was performed in shock status. After PMX, we added to treat using CHDF and HDF. Improvement of PF ratio was found during blood purification. Patient was taken vacuum closure system using negative pressure wound therapy in every day. And this slide shows that vacuum closure system in another patient with a severe abdominal sepsis. Epithelialization was found in abdominal cavity in this patient. And we performed skin grafting and flap operation. The patient was alive and discharged hospital at the 122 days. And next, toxic shock-like syndrome case. This is a gram-positive infection case. Severe blister on arm was found in patient with septic shock. And data indicate multi-organ failure and septic shock. Finally, blood culture shows Streptococcus pyogenesis. Endotoxin was negative in this case. And we tried to open the arm to check the bacterial foci. But foci were widely spread in whole arm. The patient had severe septic shock and PMX-DHP was performed more than 6 hours in spite of endotoxin was negative. Improvement of blood pressure was found by PMX. After second PMX, amputation of arm was performed. The patient also had ARDS after amputation, but improvement of ARDS was observed by civilistat, sodium hydrate, and steroid. And next, hemophagocytic syndrome. And data indicate MOF and immunoparesis. Abdominal CT revealed remarkable splenomegaly. And we can see phagocytic cells including white blood cell, red blood cell, and platelet by bone puncture. PMMA-CHDF was performed for severe sepsis and hypercytokinemia. The patient was alive after PMMA-CHDF. And in Japan, we also have a lot of hemofilter for CHDF. And these hemofilter can remove cytokines and endotoxin. And next, toxic shock syndrome by MRSA. And wound with blast was very small, and the patient had taken incision at previous hospital. Patient had DIC, disseminated intravascular coagulation status, and severe septic shock. Wound and blood culture revealed MRSA gram-positive infection. PMX-DHP was performed for septic shock. After PMX-DHP, blood pressure improved to increasing and this patient was alive. Discharge. And MRSA bacteria showed community-acquired MRSA by genotyping examination. MECA gene was found by multiplex PCR method. Genotyping showed toxic shock syndrome antigen, super antigen was gene, super antigen gene. And we can diagnose TSSS by community-acquired MRSA in this case. Final case of severe Legionella pneumonia. Legionella, you know, gram-negative bacteria. Severe Legionella pneumonia product are endotoxin. Data indicate CRP was 44.2 milligram per deciliter and severe respiratory distress syndrome. PF ratio was less than 100. Chest X-ray revealed severe inflammatory shadow. Legionella antigen was positive in urine. And this line is a PF ratio. PF ratio was very low during 7 days. We tried to improve the PF ratio. PMX-DHP was performed. After PMX-DHP, PF ratio was slowly improved. This line. And the patient moved to another hospital because vital sign and respiratory function was improved. He also was alive. And we can see the very strong effect that improve blood pressure in patients with gram-negative infection after PMX-DHP. This case is peritonitis, is bacteria, is E. coli. Cytokines including nitric oxide were decreased after PMX-DHP. This line is IL-8, TNF-alpha, nitric oxide. However, PMX-DHP has also strong effect to improve blood pressure in patients with gram-positive infection. And this case is bacteria was MRSA. And so this is our last slide. In my summary, PMX-DHP has very strong effect to improve blood pressure in patients with septic shock. And so I would like to introduce the new biomarker. Presepsin is a very useful tool for diagnosis with sepsis. Presepsin is a very rapidly and easily to measurement method for sepsis. Thank you very much for your attention. コップンカップありがとうございました。I would like forward to sing in Thailand or another country, of course in Japan again. Thank you very much.
Thank you very much, Professor Suzuki, for a very interesting lecture. You can see now that the sepsis treatment in Japan is pretty advanced. You can see that they study lots of biomarkers and also include the treatment. That I think is very interesting concept that using polymyxin with a direct hemoperfusion to remove endotoxin. And I know there is many studies showing either improvement in treatment, but there are also some studies showing that's negative studies. So I think it's still very interesting topics. Anybody have any questions or any comments about this treatment or any question for Professor? Let me start with the question first. Yeah. It seems like in patient with gram-positive sepsis, you still use PMX, right? You don't just use it in gram-negative bacteremia. Yeah. So,
sorry. If the patient with a gram-positive infection, like MRSA, Streptococcus pyogenesis, and so I will show you this slide again. Sorry. Oh, this. And so this this is schema in the pathology of endotoxin shock. This LPS and LPS endotoxin binding protein is activate using a toll-like receptor 4 way. But the gram-positive infection, this is a peptidoglucan, this way was toll-like receptor 2. A different way, but finally, NF-kappa B cells is finally activation. And so anandamide is increased and cannabinoid receptor response to hypotension, I think.
Okay. Because I think, let me explain in Thai. Okay. Yeah. ลิมิซินเนี่ยมันก็เป็นแอนติบอติกซึ่งเรามาใส่อยู่ในตัวแคทริจของไอดาไลซิสนะครับแล้วก็มาทำเป็น direct hemoperfusion เพื่อ remove endotoxin เช่น LPS อะไรเงี้ยเพื่อหวังว่าจะทำให้เกิด reaction หรือ cytokine storm น้อยลงดีซึ่งคิดว่าก็มี data ซังโปรก็คือว่าในบาง study เนี่ยก็จะพบว่ามี data ว่า improve outcome แล้วก็ลด cytokine ได้ต้องเน้นนะครับว่า cytokine ลดอยู่แล้วเพราะมันเป็น direct effectแต่ปัญหาคือว่า outcome คือ mortality ลดหรือไม่เนี่ยก็มี study หลายอย่างเช่นเมื่อสมัยไม่กี่ปีก่อนก็มีใน abdominal infection ซึ่งพบว่าลด mortality ได้แต่ต่อมาก็มี data จากต่างประเทศเช่นฝรั่งเศสว่าอาจจะไม่ลดอะไรอย่างเงี้ยนะครับแต่ผมคิดว่าโดย principle เนี่ยมัน make sense ที่จุฬาเองเราก็มีการ treatment ด้วยตอนนี้ทำอยู่นะครับก็คืออาจารย์ณัฐชัยจะทำเรื่องใช้ตัว polymyxin เป็น direct hemoperfusion แล้วก็ทำ clinical trial ในคนไข้ sepsis gram negative sepsis อยู่มีresident ที่ทำด้วยนะครับแล้วก็เราก็ทำ pilot project ไปได้คนไข้หลายคนละก็คิดว่าจะติดตาม outcome อีกที we are starting using this polymyxin hemoperfusion in our institute and we did some pilot project with many patients with Dr. nephrologist so I think this is very interesting so thank you very much for this very interesting and exciting talk I think everybody learned a lot from both the treatment and the new for sepsis. So thank you again. This is his first time in Thailand.
Okay. Thank you very much.
So he actually have only 2 nights here. So I hope you can have a chance to come back and visit us later. Thank you very much. ขอบคุณนะครับในเลคเชอร์ที่แจกไปจะมีใบประเมินด้วยนะครับก็รบกวนช่วยประเมินสักนิดนึงแล้วก็เดี๋ยวส่งข้างหน้านะครับเราจะได้เอาไปปรับปรุงในการทำซิมโพเซียมครั้งถัดไป Thank you very much ก็เดี๋ยวเชิญรับประทานอาหารนะครับเดี๋ยวจะมีอาหารทานชั้น13นะครับแล้วก็เดี๋ยวเราเจอกันอีกทีตามเดิมนะครับขอบคุณมากครับ